Good afternoon, everyone. I'm Tamiko Brown-Nagan, the Dean of the Radcliffe Institute for Advanced Study at Harvard University. I'm pleased to welcome you to the next installment in our Virtual Radcliffe discussion series, exploring health equity in the time of COVID. As I've mentioned at the outset of each of our webinars, this series reflects three critical elements of the Institute's mission. First, it reflects Radcliffe's commitment, articulated in our strategic plan, Radcliffe Engaged, to examine and address pressing issues facing our society. Second, it reflects our conviction that drawing insights from across academic disciplines and the professions allows us to advance public discourse and discern innovative solutions to complex problems. Third and finally, this series reflects the Institute's commitment to equity and opportunity. We know that COVID-19 is disproportionately affecting vulnerable and marginalized communities. Together, we have an opportunity and a responsibility to examine the deficiencies that this crisis has revealed and exacerbated, and to help chart a more equitable way forward. This discussion series is a part of that important effort. Today, we turn our attention to the specific challenges of COVID-19 in American Indian communities. Native and Indigenous people in the United States have endured centuries of subjugation and forced assimilation, and many in these communities continue to face endemic poverty and woefully inadequate health care. In that context, COVID-19 poses a new and particularly grave threat to American Indian lives and livelihoods, as our distinguished speakers will discuss. We're honored this afternoon to be joined by two guests from the University of North Dakota School of Medicine and Health Sciences. Dr. Donald Warne is Associate Dean of Diversity, Equity, and Inclusion, Director of the Indians into Medicine and the Master of Public Health Programs, and a professor of family and community medicine. He is a member of the Oglala Lakota tribe and also serves as senior policy advisor to the Great Plains Tribal Chairmen's Health Board. And Dr. Nicole Redvers is an assistant professor of family and community medicine at UND. She is a member of the Deninu First Nation Band and co-founder and board chair of the Arctic Indigenous Wellness Foundation. We're also joined by Joseph Gahn, who will moderate today's discussion. Joe is professor of anthropology and of global health and social medicine here at Harvard. He also serves as faculty director of the Harvard University Native American program. Donald, Nicole, and Joe, I'm so grateful to have you here. Finally, before our program gets underway, let me take a moment to acknowledge the members of the Radcliffe Institute Leadership Society and our annual donors. Your generosity keeps Radcliffe programming free and open to the public. Thank you so much. And now it's my pleasure to give the virtual floor to Joe Gahn.
Thank you for that kind introduction, Dean Brown-Nagan. I'll also note as an aside here that I am an enrolled member of the Aani-Grovant Tribal Nation at Fort Belknap in Montana. As you know, the problem of American Indian COVID-19 is one that requires a great deal of contextualization. So part of what we'll be hearing about today is a lot of the background about history, policy, and so on from our distinguished speakers. If you've been following the news at all, you're aware that there was an outbreak of COVID-19 in the Navajo Nation that is quite worrisome. You've also probably heard that several South Dakota tribes are in a dispute with the governor about whether to open their roads to travelers through their reservation lands. Our conversation today will be primarily USA focused because of the issues of context and background that are necessary to understand these nuanced issues. And I also want to mention that there are further resources available with web links provided on the Radcliffe website. Before we begin, I want to give a quick overview of the format for today. First, we'll have remarks by Dr. Donald Warne, followed by remarks by Professor Nicole Redvers. After the remarks, I will moderate a brief conversation among the three of us. After that, we'll respond to questions from the audience for the remainder of the program. We encourage those watching today to use the Q&A feature on Zoom to submit your questions at any time throughout the program, and we'll respond to as many as we can. And now, I'll turn it over to Dr. Warne. Don?
Thank you so much. Really happy to be here and appreciate the opportunity to share information with all of you. Again, I'm Dr. Donald Warne. I'm Oglala Lakota, originally from South Dakota, and I'm here at University of North Dakota. I wanted to start the discussion looking at some demographics and thinking about the American Indian and Alaska Native population. Of course, we are a very small population relative to the rest of the United States. In the 2010 census, there were 3 million people who identified as American Indian only. But when you look at American Indian and other race or ethnicities, there were over 5 million self-identified Indigenous Americans in the 2010 census. Of course, we have another census coming up this year. It's also important to understand that about 60% of American Indians live in urban areas. So most of us nationally do not live in reservation communities. So we have challenges related to data collection, whether it's through Indian Health Service and reservation-based, or urban Indian health centers, or maybe in cities where we don't have American Indian health services available. So IHS is the Indian Health Service, and that's the agency that delivers healthcare to American Indians and Alaska Natives. And the user population is about 2 million. So you can see the numbers, actually less than half of American Indians actually use Indian Health Service. The annual appropriation for IHS is about $5 billion, and we'll see how terribly underfunded IHS is relative to other federal programs. And also there's over 570 federally recognized American Indian and Alaska Native tribes. What's important to also understand within those numbers is that over 200 of those communities are in Alaska and over 100 are in California. So the majority of the tribal communities are in those two states. And they typically have smaller numbers and smaller land base, whereas here in the Northern Plains, we tend to have less numbers of tribes, but they're much larger in terms of land base and populations. Go ahead and go to the next slide, please. So on this map, we're looking at the concentration of Indigenous population by county in the United States. And you can see the majority of American Indians and Alaska Natives live in the western half of the United States. And there's a reason for that. Colonization occurred on the East Coast. And during that process, unfortunately, due to disease, warfare, and other challenges, many of the Indigenous populations were essentially wiped out from what is now the northeastern United States and kind of along the entire eastern seaboard. So this map would be reversed if colonization had started in the West. So we have our distribution of population really because of history and colonization. I'm gonna go to the next slide, please. So here on the left, there's actually a graphic from the Indian Health Service website, and it shows the legal basis for federal services that are provided to American Indians and Alaska Natives. And it goes all the way back to the US Constitution. There's what's called the Commerce Clause in the Constitution, Article 1, Section 8, and that states that Congress shall regulate commerce with the foreign nations and the Indian tribes. And that's seen as kind of the starting point of federal Indian law recognition of tribal sovereignty. Of course, tribes have considered themselves to be sovereign long before there's a constitution, but in the US Constitution, tribes are put on par with foreign nations. We also have a lot of treaties. There's several hundred treaties that were signed between the tribal nations and the federal government. And this is one example of a treaty with the Potawatomi Nation in 1846. And I know it's in very small print, but at the bottom you can see that it states that the United States will give at the same time promise of all proper care and protection. Promise of all proper care and protection. And this really is seen as the basis for the federal trust responsibility to provide health services to American Indians, because this is common language from many of our treaties, in that the US is to give promise of all proper care. Next slide, please. But unfortunately, we haven't seen all proper care. We call it the ITU system. There's the Indian Health Service, which was formally established in what is now Department of Health and Human Services in the 1950s. And the funding is authorized through what's called the Snyder Act from the 1920s. So we actually have had a long history of an Indian Health Service or Indian Health Program here in the United States. In the 1970s, tribes were able to take over management of the programs through Public Law 93-638. So we have tribally delivered services, and we also have urban Indian health centers as well. So we could have one patient who is seen in an IHS facility, a tribal facility, or an urban Indian health facility. So it is a relatively complex system. And the way we respond to a problem like COVID-19 really does depend on the delivery system and access to services locally. Go ahead and go to the next slide, please. So this is showing the amount of funding per beneficiary for various federally funded systems. On the far left is Medicare spending per beneficiary at over $12,000 per person per year. You can see for veterans, it's about $8,700 per person per year. Medicaid, nearly $6,000 per person per year. And for Indian Health Service, about $3,000 per person per year. So as you can imagine, there's a great deal of challenge in trying to respond to a pandemic or any public health emergency, or even managing chronic disease when our health system is so terribly underfunded. And in addition to providing medical services, Indian Health Service is also supposed to be providing public health services. So go ahead and go to the next slide, please. So within the context of underfunding and challenges, when we think about the impact of COVID-19, we have to have good public health infrastructure to have an adequate response. And unfortunately, due to decades of underfunding, we have a weakened public health infrastructure in many of our tribal communities. So when we think about the 3 T's of testing for COVID-19, contact tracing for those who are positive, and then of course treatment, we have a lot of limitations in the Indian health system because of lack of resources. So this has had an impact on public health infrastructure and even sometimes challenges in accessing personal protective equipment for our providers. Go ahead and go to the next slide, please. And this is our last slide for my presentation, but what we're doing here at University of North Dakota, we are working with the state of North Dakota, and we have Master of Public Health students and other graduate students working in contact tracing. And we're also working with some of the tribal communities in the Great Plains area to try to assist in purchased and referred care coordination. Because of underfunding of our systems and the rural nature of our communities, we don't have intensive care units in most of our hospitals or ventilators and those types of high-level services. We have to be able to engage the private sector. Also, what we're doing here at UND, we have an Indigenous health focus in our Master of Public Health, so students can specialize in Indigenous health to get their MPH. We're also very excited we have a summer, and we're hoping that people who are trained with the Indigenous health PhD will be in the future our frontline responders to these types of challenges that we're facing. Kind of a brief overview of Indian health system and some of the challenges that we face, and very happy to turn it over to my colleague, Dr. Nicole Redvers, and she'll be able to go into a little bit more detail on some of the other aspects that we are addressing. So I'll go ahead and hand it off to Nicole.
Hi there. Hi, everyone. Thanks, Dr. Warne. That was a great introduction and segue into my portion of the presentation today. And it really sets the stage for, some of the actual on-the-ground public health challenges that we are facing right this moment in many of our communities, not only here in the United States, but elsewhere too in the world. One of the things that, I think is so unfortunate is due to this underfunding crisis that Dr. Warne was talking about. We have glaring health disparities in our community. Pretty much any statistics that you can look up, whether or not it's prevalence of diabetes, whether or not it's life expectancy rates, our American Indian communities are continually some of the worst within the nation. Even for diabetes, our prevalence are 16%, almost double the non-Hispanic white race level. And on top of these disparities, the challenge being from a COVID perspective is that when we're trying to implement basic public health measures, even such as encouraging people to wash hands, it becomes very tricky without the public health infrastructure that currently exists. It's about 58 out of 1,000 Native American households in the United States lack access to running water. And that's compared to about 3 out of 1,000 in our non-Native households. And, Navajo Nation was brought up. Their rate is about 30% of the reservation without access to running water. So you can imagine being a public health department trying to implement washing hands or even cleaning of surfaces without access to some of our basic necessities within these communities. One of the other challenges with COVID, particularly from the public health standpoint, is that we have about 1 in 6 households that are considered to be overcrowded. And that could mean 2 or 3 families within a household, even with 2 bedrooms. So the aspect or the ability to social distance becomes very, very difficult. Next slide, please. And, you know, with the language barriers, this will depend on communities around the United States. Some of our elders particularly don't speak the English language, and they only speak some of their Indigenous languages. So for communication, you know, with these patients or potential patients, even trying to get education materials out can be very challenging. Not to mention the lack of internet access that plagues many of our reservations. And again, I keep bringing up Navajo Nation because there has been a lot of publicity around it lately with regards to the caseload. But on the Navajo Nation, we have about 30% of homes that don't even have electricity. So you can imagine that leads to about 30% of homes not being able to have internet access. So there's a lot of creativity that needs to go into how we address public health communications with homes that are often spread out over rural areas, language barriers, and then of course trying to work with households when there is overcrowding presence or lack of access to running water. Next slide. But one of the things I think which is important, and you know, this speaks to me personally because, and probably to many people that have had family members that have experienced the Spanish flu. I'm originally from Northern Canada, and both my great grandparents perished from the Spanish flu. They were one of many Indigenous families within that area that were completely wiped out by the last pandemic, and it changed the course of our family lineage from there on in. My grandmother and her siblings were left parentless at the age of 5 and sent to Indian boarding schools, which were a little different than the boarding schools that we think of today. And, you know, changed sort of the course of how our family dynamics worked from there. So I think the aspect of these pandemics are very much raw within many of our current families today. You know, we remember within our family lineages what happened with the last one. So we're particularly sensitized, I think, to the potential impacts. But what's been amazing also throughout that is that we are still here today. And, you know, the signs of resilience within the communities has been unbelievable. Joe mentioned at the beginning about some of the tribes taking sovereignty very seriously in this regard and putting up things like roadblocks or road closures, making mask mandates within their communities, having weekend curfews, all of these types of initiatives self-run within the tribe to try to control as much as possible the spread of COVID within communities. One of the things that has been particularly challenging, though, is many of our ceremonial practices and our ability to be resilient comes from being together. And that's through gatherings, through feasts, even through things like pipe ceremonies, sweat lodges where we gather and there's close contact. A lot of those things have had to been postponed for the time being. So I know there is some difficulties for community members not being able to gather in their sacred ways and being able to practice some of their ceremonies as they usually do. And lastly, I think, I want to mention how important our elders are in our communities. They really are our lifeline and our knowledge holders, our knowledge keepers. So I think, I've just seen an amazing effort on behalf of our communities to try to protect our elderly and make sure that we have knowledge passed down to the next generation. So, through the difficulties that we talked about, I also see signs of hope. We have a lot of challenges yet to come, but I'm hoping that with everybody working together that we'll have possibilities to move through this as we go forward. So with that, I'd like to pass it back over to Joe, and looking forward to having a conversation with Don as well.
Terrific. Thanks, Don and Nicole, for these illuminating presentations. There are just so many avenues to explore further here. One question that bedevils every Indian health issue in the USA pertains to funding. What should tribal nations be doing to effectively manage this pandemic when federal resource allocations are so limited and when their local economies are so vulnerable right now? Don, what are your thoughts here?
Yeah, that's a great point. And one of our big challenges in Indian health in general is not only do many of our populations live in poverty, so the individuals don't have a lot of resources, our health system has been impoverished for decades. So we just don't have the infrastructure in many places to have an adequate response when there's something like a pandemic. And we also have to remember that each tribe is different, each community is different. Some communities are doing very well financially and have resources, but many of them do not. So there's not kind of a one-size-fits-all approach that answers that question adequately. But one good thing that's happened is we have seen more resources allocated for COVID response that's going to tribes in some cases, but also to Indian Health Service. And with increased resources, we're hoping that we can try to make up for some of that lack of infrastructure. But I think the bigger picture issue, of course, this is a once in a century pandemic that we're dealing with right now. I've heard a lot of people say, when are we going to get back to normal? And in truth, I hope we don't get back to normal. I hope we get back to better, that maybe this will be illuminating enough to recognize that people will suffer and die unnecessarily when we have lack of investment in public health infrastructure. So I think we have to respond to the emergency and the crisis right now, and tribal leaders in many cases are doing great work on that front. But we also have to look at this as an opportunity to shed light on these challenges and try to fix them as we move forward.
Thank you. Another question that comes to mind concerns knowledge about the impact of the pandemic in Indian country. It's so difficult to mobilize an effective community response in the dark, so to speak. What should tribal nations be thinking when it comes to issues of data capture? Nicole, what's your perspective on this issue?
Yeah, this is a really, really important question, I think, for all communities. Is without, having adequate data, it's really hard to be able to mobilize and plan any public health response against any issue facing the community. And one of the things that's interesting, given what Dr. Warne had mentioned in his presentation, is the difference between the IHS-run facilities, the tribal-run facilities, and the urban-run facilities. Is the IHS itself is required to report COVID cases. Currently, right now, they don't actually report death at all. It's stated that there's too much inconsistencies with the data, so right now they are only reporting cases. However, the tribal run facilities, in addition to the urban clinics, it is not mandatory. It's they can choose to self-report cases. And this is partly due to tribal sovereignty, meaning that tribes have the right and the law to be able to collect their own data and use it as is. However, without consistency in terms of reporting across the nation, it becomes very difficult to have confidence to know where adequate resources are needed, where to be able to send those funding dollars that Dr. Warne was talking about, who needs ventilators, where do we need to prep, and all of that's complicated by minimal testing, outdated technology, as Dr. Warne was talking about, provider shortages. So it really leads to a vastly underreported crisis in many cases, which I think is true in all areas of the US right now, but I think it's particularly true within Indian country. So I'm hoping, and we're seeing signs of this, where data conversations are happening, particularly at the National Indian Health Board level, to try to get a better handle of what's going on in Indian country.
Very interesting. It's not especially surprising that COVID-19 would wreak havoc on any historically oppressed and deeply impoverished community. What do you think are the most distinctive aspects of this pandemic when it comes to tribal nations in the USA? Don?
Yeah, and again, we have such diversity with tribal nations, and some of our tribes are, again, having good response and adequate contact tracing and those types of things, but there's other communities that are really struggling, again, based on longstanding poverty and not having enough resources. So some of the things to keep in mind from a policy perspective, sometimes the tribes and the states work collaboratively very well, sometimes they do not. And I think you had mentioned in your introductory remarks, where I'm from in South Dakota, there's always been some tension between state government and tribal governments, and that can actually even make itself apparent during the time of a crisis like a pandemic. And unfortunately, we deal with those types of challenges. So there's challenges in terms of the tribes facing poverty, but also working collaboratively with the state and working collaboratively with the private sector. And then from a cultural perspective, for so many of our communities, We're even having to look at canceling annual events like Sundance and other sacred ceremonies that are so vitally important to our cultures, but recognizing that in response to the pandemic, we're actually having to, in many cases, cancel or postpone cultural events as well. And even just interpersonal cultural practices, a firm handshake in many tribes is so vitally important, and trying to encourage our people not to do that. There's a kind of an extra layer about just the general public health considerations, but also the cultural considerations. So what I've been very happy to see is that in many of our communities, we have traditional healers and traditional leaders really leading the effort in terms of trying to educate people. And we just need to get through the pandemic and then get back to our cultural practices.
You know, we've been focused today primarily on American Indian communities in the US, but Indigenous peoples exist and persist around the world. What insights can you offer about managing this pandemic from an international Indigenous perspective? Nicole?
Yeah, it's very interesting to see some of the communications that have come from the global level, from the UN Permanent Forum on Indigenous Peoples. You know, there's a number of organizations that are being very active right now in mobilizing both resources but communications, and using this as an opportunity to be able to leverage successes and what's working in some areas, because unfortunately, you know, despite the diversity of Indigenous peoples around the world and the need to avoid sort of a pan-Indigenous viewpoint of Indigenous peoples, we do share a marginalization generally around the globe, where many Indigenous peoples face very similar challenges in terms of poverty, racial discrimination, low income, lack of access to running water. These things spread the globe. If we even look north of us to Canada, we have 61 communities, reservation communities, on what's called long-term water boil advisories. So even though there's access to water, the water is not safe to drink. 22 are on short-term water boil advisories. And places like Guatemala, we have 90% of Indigenous people in rural communities not having access to running water. So, you know, these threads run through many of these communities. Land dispossession, we're seeing unfortunate states. We've heard news out of Myanmar recently of some of the Indigenous peoples having forced removals during the time of COVID. So we're seeing some governments using this as an opportunity, the COVID crisis, to be able to carry out policies that they were maybe not doing so much before. So it's just very challenging on a whole, with all of the issues going on around the globe. I'm hopeful in terms of the new partnerships that are coming about because of the crisis and the need to stick together in the commonalities that Indigenous people are facing around the world. I think there's this sense of strength between all of us, knowing that we are facing very similar issues. But the one thing I think that is inspirational is that many of our Indigenous communities have prophecies that have existed for decades that foretold a infection coming to the world just like this. And many of the Indigenous communities have put out statements, one particularly from Levi Sucre Romero. He's Bribri from Costa Rica, stood out, and he kind of sums up exactly what I've heard from many of the Indigenous communities, and that is that the coronavirus is telling the world what Indigenous people have been saying for thousands of years, that if we do not help protect biodiversity and nature, we will face this and even worse threats. So there seems to be a connection of many Indigenous nations between COVID and the need to be able to have a new way of living. Just as Dr. Warne was talking about before, we cannot go back to normal. We need to look at things differently and start reconnecting to our original ways to be able to avoid continued problems, because they will continue to happen if we continue along this line.
Thank you. Okay, we want to move shortly to Q&A, but first we have a sizable audience today, and I'd like to hear from both of you in turn in response to one final question for this part of the program. Many of our audience is wondering what they can do to contribute to, advocate for, and otherwise support American Indian communities during these troubled times. What suggestions can you offer for ways that non-Indian people might help? Don?
Yeah, that's a great question. And I think that one thing that we could have done historically is provide better avenues and easy opportunities to help, because I know there's a lot of people out there that recognize that this is a challenge and want to be a part of the solution. A few things that I would recommend. One is to look at some of the regional and national tribal health boards. So there's the National Indian Health Board. It's a not-for-profit corporation that does represent the vast majority of tribes in the United States in the 12 areas of the Indian Health Service. And they do a lot of work for advocacy and public health programming at the national level. So if there's ways that you can help them, that again, it's a nonprofit corporation. In addition to that, we have 12 regional tribal health boards, and they have tribal epidemiology centers, but they're always struggling for resources. And that's one way to assist either at a national level or at a regional level by contributing or assisting with whatever capacities or expertise you have with those organizations. In addition to that, we also have to recognize that much of the challenge we're facing is related to bad policy and bad legislation and not holding up our treaties. We have treaty rights. Treaties are the highest order of law in the land, but the federal government is in violation of those treaties by not adequately funding things like health services. So I think we also have to be involved politically and ask our people who are running for office, what are their perspectives on upholding treaty rights for Indigenous peoples right here in the United States?
Thank you. And Nicole, what are your thoughts about how the audience might be able to contribute to and support American Indian communities at this time?
Yeah, I want to echo Dr. Warne's comments. Definitely, I think we need a lot of allies out there in support of this work, but we also need doors opened as well too. Dr. Warne mentioned that we're launching the very first PhD in Indigenous health in the fall, and sometimes I think, wow, it's 2020, and this is the first time ever in North America we have an Indigenous health PhD. It shouldn't have taken this long. So I think we need more advocacy within university environments, research environments to ensure that we have space for opening up opportunities to Indigenous students, to Indigenous medical students, to prospective Indigenous researchers, from grant funding agencies, supporting communities to do their own community and tribally driven research. I think these are the things that help to mobilize self-sustainable communities based on the historical unfortunate events that have happened over the while that were really not the fault of Indigenous people. So I think the more that we can support self-resiliency and getting back, we have so many skilled and amazing young people coming up in our communities, but they just don't have the access sometimes to the opportunities that those do outside the communities. So I'm hoping that, through this event, and we can use this as an avenue to find different ways to support Indigenous communities, whether or not it is actively through some of our health boards, nonprofits, but also for opening up access to educational opportunities, environments, fellowships, those types of things as well.
Wonderful, thank you, and thanks for this enlightening exchange. We want now to proceed to Q&A with our audience. Here's a question that's come in, and it's specifically about the Navajo Nation, but if we don't know the details there, we could broaden it out a little bit. But the question is this: is the medical care available to the Navajo Nation substantially more deficient than the care that's available to other Native groups, such that it's necessary for Doctors Without Borders, say, to help the Navajos in particular? Why is additional medical care needed? Don.
Yeah, I can try to take the first approach to that. And of course, I'm not Navajo, and I would defer to any members of Navajo Nation or the Dene people that might have other perspectives to respond as well. But certainly thinking about the health systems throughout Indian Health Service, again, they're all terribly underfunded. And in some of our larger communities like Navajo Nation and many of the Lakota and Dakota communities up here in the Dakotas, we tend to have higher concentrations of people with high rates of poverty and substandard public health systems. And again, it's not the fault of the tribes. If you don't have resources, you can't build public health infrastructure. So I think it's unfortunately in some communities where they've had early exposure to the virus in large gatherings of people, they're just at higher risk for spread of the disease. Other considerations for tribal communities: we have higher rates of diabetes. Here in the Northern Plains, we have higher rates of cigarette smoking. So many of our people are also at much higher risk for getting COVID-19, but then also having bad outcomes as a result. So I wouldn't say that the Navajo health system is substantially worse than what we have here in the Great Plains, for example, but I think that they had some early exposures and in large gatherings that allowed the virus to spread very quickly. It's a highly contagious virus. And I think if that were to occur in just about any American Indian community with large population, we would see a similar outcome. So much of it is just, unfortunately, they had early exposure to the virus.
Thank you, Don. Here's another question we have from an audience member. What are your thoughts on how this crisis is being covered and in many ways not covered by the national media? What would you like to see change? Nicole?
Yeah, I think this is, always the big question when it comes to issues in Indian country is that, before it sort of becomes a fight like we saw with the South Dakota governor recently that both Dr. Warne and you mentioned about is, until there's a crisis, until there's a fight, that's usually what we see being publicized on the news, as opposed to focusing on the real issues, which is the impacts of the virus on communities, the lack of resources for communities, and how they're able to respond to the pandemic. We had one case in Seattle where the urban Indian health clinic within that area was ordering PPE supplies. And when they received the PPE, they opened the box, and instead of finding PPE, they actually found body bags within the boxes. So you can imagine the feelings that came about of expecting protective equipment and actually finding body bags instead. So these types of issues, they just sort of come to the forefront of media, but it ends up focusing on some of the unfortunate difficulties that we still face that are more political, as opposed to again, as mentioned, the real issue of this virus. So, I'm hoping as we move forward that we're going to work together as a community to better mobilize and possibly being able to use this instance of the pandemic as a leverage point. We've saw recently Ellen DeGeneres and a number of movie stars, for example, doing spotlights on Navajo Nation. Sometimes it takes a crisis, unfortunately, to be able to see what's going on in some of these communities. I wish it wasn't the case, but we continue to see that challenge within how our communities are represented at the media and at the national level.
Okay, here's another question. What are public health education strategies that tribal healers and leaders have been utilizing, and how have they been received? And without electricity, how can people stay connected? Don.
Yeah, this is a very good question. So just kind of looking at the first question, of course, each tribe, again, is different, and we have different capacities in terms of traditional cultural leaders and medicine people. I'm very proud of one of my uncles, Rick Two Dogs, who is from Porcupine, South Dakota on our Pine Ridge Indian Reservation. He's been using social media to send out words of encouragement, but also really embracing the need for good public health response. So I've seen case examples where we have our traditional healers and highly respected people in our communities helping to champion the appropriate messaging to our populations. And that's so vitally important because in truth, in many of our communities, people will listen to the medicine man long before they'll listen to the highly educated physician with the PhD, for example. So that's one example. And then also just the idea of not having adequate electricity or even internet connectivity. And in some cases, people don't even have phone lines. So quite often because of poverty, a lot of our people use disposable cellular phones. So not only is that a challenge in terms of a public health response, how do you do contact tracing when you have a lot of people who don't have the same types of connectivity for communication? So it makes it incredibly complex. So that's why I'm glad we're having this type of a discussion, because that does need to be part of the national dialogue as well.
Great. Nicole, here's another question pertaining to First Nations in Canada. Do you know how the status of U.S. Indigenous situations compare to those in Canada for First Nations?
Yeah, so in terms of general health disparities, it's very much similar between the Canadian and the United States landscapes. Prevalence of diabetes, underlying chronic health conditions, those are challenges across Turtle Island or across North America. There is a huge political difference in terms of the operation of the health system within Canada compared to the United States. Obviously, we have a publicly funded health system in Canada. However, a lot of our reservation communities are most often very isolated, so they often don't have access to the same publicly available care or to the same standard as some of the other more urban centers. We also have issues in terms of transportation, particularly in our rural areas, where same thing in the United States, we just don't have access to ventilators or other types of ICU settings. So a lot of patients end up being shipped out to various locations to be able to get care. And one of the things that I have seen quite amazing in the Canadian context, and I've been proud to see some of the northern governments in particular, is really advocating for a lot of our Indigenous families and communities to get back out on the land as part of their self-isolation, instead of actually isolating at home or doing social distancing at home, or physical distancing at home, I should say. Many people are being encouraged to go out on the landscapes back to their traditional cabins and homelands to be able to spend time and reconnect with their traditions, utilize their traditional foods. So it's been nice to see that messaging happening, and even funding coming through to support families to do that.
Okay. Here's another question. Are there messages regarding social distancing or physical distancing that would resonate with American Indian youth and adults? Don?
Yeah, and again, with the diversity among our tribal nations, there's not one size fits all. So I think what would be most effective is working with each of the tribal communities to identify who are the champions within that community, who is well respected and would be listened to in terms of messaging. In some cases, it would be an elected tribal official. In some cases, it would be a traditional healer. In other cases, it might be the health system or the health director. So I think that the key is to ensure that the messaging is being delivered by well-respected community leaders, whether they're formal leaders or informal leaders. And in Indian country, just like in many populations, the messenger really matters. So we should be engaging well-respected community champions to help deliver those messages, like social distancing and staying at home as much as possible, not shaking hands, all of those considerations. So I think that's one of our unique challenges in public health education for tribal populations and other Indigenous groups, is that the messenger matters. And that's part of our strategy, is to engage communities and identify who are those champions who can best deliver the messaging.
Both of you have mentioned traditional healers, and here's a question pertaining to that. Do you have comments on any known role of traditional Indian medicine for COVID-19? Nicole?
So in terms of any traditional medicine therapy around the globe, for that matter, we don't usually have scientific random control trials in terms of our traditional medicines. In fact, many Indigenous people don't, or have a lot of mistrust with regards to research around our traditional medicines. So obviously with that, we can't say from a Western standpoint that any traditional medicine is used specifically to treat COVID. Having said that, there's a number of traditional medicines that have been used historically for viral infections, colds, all sorts of ailments. That's why we're still here today, because we've thrived on our own medicines for thousands of years before the coming of Western medicine. So I think, a lot of our people are increasing use, from what I've seen, of some of their traditional medicines around their homelands, utilizing things like smudge to be able to, help themselves throughout this time. So I've been, happy to see that uptake of use, because given the lack of resources and access within our communities, I think anything that we can do to support ourselves right now is going to be of benefit. And I can see, as Dawn mentioned too, that a lot of our traditional healers are really taking leadership within our communities to help support, but also seeing communities supporting our healers too, and making sure that people are not burdening them with questions and informations, and ensuring that they're also protected, because many of our healers are also elders and in the at-risk range for COVID as well.
Great. So we're all three educators, and you two in particular are about to launch your doctoral program in Indigenous health. And so here's a question about students. As universities are thinking of making the next semester fully remote, how can we improve access for students from Native and tribal lands? What types of measures do we need to take to ensure that they have equal access to education? Dawn.
This is a big struggle. And in addition to our Indigenous Health PhD program that we have at UND, we also have the Indians into Medicine or InMed program. And with that program, we actually have summer programs that last for 6 weeks for middle school and high school students to spend time on campus, live in the dorms, and take science-related courses. So they have biology, chemistry, physics, mathematics, and communications. And because of the pandemic, that entire curriculum has now had to move to distance formats. And one of the challenges that we are facing is that we do not always have reliable, high-speed internet connectivity in our tribal populations. I mean, that's even true in cities. I've been on a number of conference calls where people living in a city have a difficult time with enough bandwidth for Zoom calls and having kids at home trying to go to school remotely as well. So it's a big challenge just looking at the infrastructure related to internet connectivity. And again, I think this pandemic is shining a bright light on a multitude of inequities, including just simple communications that many of us can now take for granted if we live in a city. So there's that component of it. And in addition, one other key strategy would be to work with tribal colleges. And the tribal colleges, particularly here in North Dakota, we have 5 tribal colleges. And they have a vital role in connecting with students. And I would love to see stronger connectivities between universities like UND and others and the tribal colleges to help facilitate distance learning, and perhaps having a hub like a tribal college where they do have, in most cases, better internet connectivity. That might be a way to reach more students. And I'd also point to the American Indian Higher Education Consortium, or AHEC, and that's a consortium of the tribal colleges and universities. So there's some infrastructure in place, and perhaps because of the pandemic, we can have new strategies to better engage more students.
Those are wonderful recommendations. Nicole, here's another question. We've heard about domestic violence and sexual violence being on the rise during this pandemic. How has the Indigenous community seen this correlation during the pandemic?
Such an important point to bring up, especially since we just recently had our Missing and Murdered Indigenous Women Day within the last few weeks, where we saw a lot of women around the nation wearing red in honor of our missing and murdered Indigenous women. And I think, there's been a lot of concern in our communities about women and families and children, but also men as well in homes that are unsafe and not having the ability to go. The issue that we're seeing is we're not seeing a lot of data. The data that we are seeing is that many of the homes that used to receive women in states of crisis, shelters, those types of things, have often seen a drop in attendance. In fact, some of them have not seen any clients within the last few weeks, which is very concerning, because what it's either demonstrating is that women are either afraid to come to these services, or they're facing other barriers to be able to get out of the home and get to a safe place. There's a number of organizations that are working very hard right now to be able to reach women in crisis, including using code words and other things that are being published internally to help identify women that may be facing unsafe situations and don't feel that they're able to get out of the house or get out of the environment that they're in. So I've been heartened to see the mobilization of this effort. There's a lot of work and support that needs to be done in this area. Our statistics are very dire within our communities. Most of our Native American women are perpetrated by non-Native American people. And we're very at risk, not only in rural areas, but also in urban centers as well. So, I'm hoping with the great activism that many of our Native women are doing through the Missing and Murdered Indigenous Women movements, that we'll see more publicity around this and more action on the both the state and the federal level.
Thank you for that. We've had a number of questions about behavioral health issues or mental health issues. So Dawn, has there been any focus within tribal communities on mental health throughout this crisis? what is the thought or feeling surrounding mental health within our communities?
Yeah, that's a great question. It's so vitally important. And there are efforts to address the mental health outcomes of the pandemic, and probably not enough effort on that front, to be quite honest. As we know, anyone going through this pandemic is at higher risk for things like social isolation and potentially more substance use, self-medication, and depression. And that's one reason I don't like the term social distancing. It should be physical distancing. If anything, we need social connectedness with each other at this time more than at any other time. So in terms of the impact, unfortunately, for many of our tribal populations, we do have higher rates of depression, higher rates of post-traumatic stress, higher exposure to adverse childhood experiences, and then subsequent self-medication, unfortunately. So we do see some pockets of our population with higher risk for substance abuse and even higher rates of suicide. So our populations are at tremendous risk, not just in terms of the virus and the physical outcomes and risk factors like diabetes and smoking, but even higher risk for bad outcomes from a mental health perspective. So that needs to be a part of the equation. And I know that the resources that are being put out by the federal government do address mental health considerations as well. But each tribe is so unique, we need to have tribal specific plans to address mental health, behavioral health outcomes in the midst of the pandemic. And whoever asked the question, thank you for asking that, because it's a vital component of what we need to do.
Nicole, there's been discussion concerning Alaska Natives, American Indian, and Indigenous communities worldwide, but one audience member was wondering, what is the impact for Native Hawaiians? Do we know anything about that at this point?
Yeah, I'm not as familiar with the Native Hawaiian community. I have heard communications that they've been putting out a lot of notices to try to, similar to tribal communities here, discouraging people to come visit some of their communities and areas. They're really trying to keep as many people out as possible that are coming. But aside from that, I'm not sure, Doctor, if you're familiar with any of the things that are going on in that area.
No, I haven't been able to keep up with all of my friends and colleagues in the Pacific Islands. And I know that, again, the populations, whether it's Indigenous peoples in Hawaii, Guam, other Pacific Islands, New Zealand, Australia, we share so many commonalities in terms of marginalization and colonization and poverty that all the populations are at great risk. Sad to say I haven't kept up with the numbers and to see exactly what the data show us, but I know the populations are at tremendous risk, and we do need to be banding together around this challenge.
Okay, I think we have time just for one more question, but I'll give you each a turn at addressing it. Here is our final question from an audience member. Where in the public healthcare system would you prioritize investment for the next decade? Development of public health trainees, health workforce, water access, IHS funding to the need that's overwhelming at times, or something that the audience member is not considering. Nicole, your thoughts?
Mm-hmm. Wow, isn't that the big question? It's so complex. I often think about this, if we were to get a check written, where would we need to put the effort to be able to make the most difference given the huge issues that we face. And just thinking about the structure of where health comes from, and knowing that up to 80% is due to our socioeconomic status, where we live, our employment, all of those other aspects outside of medical care, and only 20% of what makes us well being implicated by medical care. I would have to say that we need to focus on that other 80%. The socioeconomic status, the housing, the water issues, all of that piece needs to be focused on, in my mind, more than the medical care piece, even though that's still important. And that's why it's always hard to have this conversation. It's sort of the what if, but I think if we don't have the foundations there, we can have the best medical systems in the world. But if people are not having homes, if they're not having access to clean water, we can do everything till the cows come home, and it's really not going to make the impact that we want at the hospital level.
Don, any thoughts about where best to invest in the public health care system in the next decade?
I agree, that is the big question. And the answer, quite honestly, is all of the above and then some, because we have so many challenges and lack of infrastructure. So if you just look at the framework for public health infrastructure, you have to look at physical capacity, so buildings, laboratories, all of those types of things, but also workforce capacities. You have to have people who are able to do the work in public health. And we have had a shortage of people who are well-trained, particularly in American Indian and Indigenous public health principles. And then you also have to have good information and data systems. So I kind of think of those three components kind of as the skeletal system, the muscular system, and the nervous system of public health infrastructure. And you cannot build good responses or programs without that foundational infrastructure. So that's the one big piece of it. But I would also agree with Nicole that we should be looking at things like economic development as public health investments as well. When people are living in poverty, they're going to be at higher risk for bad outcomes. So we have to broaden our view of public health and recognize that economic health is a part of that as well. And I know we're coming to the end. I just wanted to quickly say thank you to Radcliffe Institute for hosting this and acknowledging American Indian and Indigenous populations in this response. And Joe, you did a great job trying to balance quite a number of questions, and I really appreciate your efforts too. So thank you very much.
Yes, thank you, Joe. Thanks, everyone.
Well, thank you so much. Your answers have been penetrating and illuminating, and we're very grateful. So thank you again for participating in our program today, for your very thoughtful presentations and perspectives, and for the critical work that you do every day. I also want to thank our audience for the terrific questions. I hope you'll be able to join us for Radcliffe's next virtual seminar entitled Equitable Readiness, Reimagining the Role of the Public Sector in the Wake of COVID-19, which will be on Thursday, May 21st at noon. Further information about this program or others will be found on Radcliffe's website, radcliffe.harvard.edu. We hope to see you then. Thanks so much, everyone.